Hi, everyone. My name is Rich Savel,
My name's Krista Lenzi. I'm the clinical pharmacist in the surgical ICU.
and today we are going to be talking about how to dose amikacin in the intensive care unit. This is important because it is recommended in our unit that an aminoglycoside be given in addition to other empiric antibiotic therapy, and I wanted to work with Dr. Lenzi to try and clarify some of the issues about how we dose aminoglycosides and why we dose them the way we do. So let's have at it.
Let's do it.
So the first issue here was that the type of dosing that we are discussing is called extended interval dosing. So the first statement is that we're using aminoglycosides to help make sure that we are getting appropriate broad gram-negative coverage for patients who are in septic shock. And the interesting issue related to aminoglycosides is that they have, as is clearly documented in the slide here, concentration-dependent killing. And the concept is that you are trying to strike a balance between the maximizing the efficacy of the antibiotic and minimizing the toxicity of the antibiotic, which, as most people know, are nephrotoxicity and ototoxicity. And it was discovered in the last 15 years or so that if you dose aminoglycosides in the way that we're about to describe, you maximize their killing while minimizing the toxicity. And the idea is you give a larger dose less frequently, and it takes advantage of, as is described here, concentration-dependent killing, and it takes advantage of what is known as the post-antibiotic effect.
Correct.
And so the part that can often be confusing for physicians is, even if you understand what we're talking about, how do you translate that into actually dosing the aminoglycoside properly? So let's move on to the next slide.
Okay.
Now, you told me there are some examples in which you shouldn't actually use this extended interval dosing.
There are some instances where we should not be doing extended interval dosing. Primarily, renal insufficiency is what we're most worried about. Additionally, any patient who is pregnant, has ascites, burns, should also be excluded from once daily or extended interval aminoglycoside dosing. Additionally, in meningitis and endocarditis, it has not been adequately studied.
And then you were telling me before, and we're not going to go into it in this video, but that you would then use the standard traditional
dosing, correct.
So when you first showed me this slide, I was pretty excited. So amikacin, 15 milligrams per kilogram once daily, or at least that's how you decide your first dose, ideal body weight. So ideal body weight, you just ask the patient what they would like their weight to be, and that's their ideal body weight?
I wish it was that easy. So there are different equations for calculating ideal body weight for males and females. I don't expect everyone to memorize these equations, but here they are for your reference. So if the patient is close to their ideal body weight, that's how we do it, 15 milligrams per kilogram ideal body weight. If a patient, however, is obese, or if they are greater than 20% above their ideal body weight, that's when we then use what we call the adjusted body weight or dosing body weight. I would strongly advise that you coordinate with pharmacy in calculating these equations.
So let me just summarize so far. I should be giving an aminoglycoside as part of my routine empiric therapy for my patient in septic shock. I should be trying to use the extended interval dosing whenever possible because it maximizes killing and minimizes toxicity. And you gave me some examples of patients that I shouldn't be doing it in if they have significant renal insufficiency, if they're pregnant, ascites, burns. Those are some of the big ones.
Very good.
And then you were telling me that it's amikacin in particular is 15 milligrams per kilogram, ideal body weight, which, as you said, we can coordinate with pharmacy to get help, that there are two different equations based on gender, and that if they're above 20%, if their actual body weight is 20% above their ideal body weight, there's a separate equation that you guys help us with to figure out the dosing weight.
You said it perfectly, Dr. Savel. The only other point I just want to drive home, which Dr. Savel mentioned earlier, is the whole concept of double coverage, so that this is not your only source of gram-negative coverage. This is in addition to other gram-negative agents such as cefepime, piperacillin, tazobactam, or meropenem. This is in addition to those agents.
So I'm going to go on to the next slide because So we've given the dose, and that's it. We don't have to ever give another dose.
Again, I wish it was that easy, but unfortunately, it's not that easy once again. So amikacin monitoring, it's important to, when you order amikacin, to order a level for, I usually advise 10 hours after the dose has been given. So you want it between this window of 6 to 14 hours after, and then you plot it on what's called the Hartford nomogram for aminoglycosides, which some of you may remember from school. Now, what's very important here, I just want to point out, is that for amikacin, we want to divide whatever number you get back in the computer, divide that number in half. You can then plot it on the nomogram, at 10 hours. I'll go through an example here in a minute, and that is going to help determine. This is showing whether the patient is actually eliminating the drug properly, and then if it's necessary to continue dosing amikacin, this will help you in determining the frequency at which to dose it at.
So you coordinate with the nurse to make sure that it's clear when the first dose was given, check a level 10 hours later, whatever value you get, cut in half, and use this nomogram to determine whether you're going to, if you need to keep giving it, give it once a day, once every 24 hours, 36 hours, or 48 hours. And as you and I were saying before, clinically, the way we recommend determining that is based on your culture results. If the patient has cultures that come back and it shows you have an organism that's sensitive to other antibiotics, then you don't need to continue to give the aminoglycoside. That's in general how we do it.
Yes, absolutely. And the only other thing I want to mention is that this monitoring of these levels is important because we can determine possible toxicity. So the two most notable ones, which Dr. Savel mentioned earlier, are ototoxicity and nephrotoxicity for amikacin. So do you want to
And then you wanted to conclude by going over an example.
So we'll just go through this this as an example. We give a theoretical patient here. We're saying that the patient yesterday got amikacin at 1 p.m. And the level came back as 8 micrograms per milliliters, which was drawn 10 hours later. So what frequency should this patient be dosed at? So we know that the time difference between administration and the level being drawn is 10 hours. You then divide that number by 2. Again, that's, if I can emphasize one thing, it's very important. So we divide that by 2, which gives us a concentration of 4. So then you can see here, we fall within the Q24-hour dosing window. So let's say for this patient that they're growing gram-negative rods, but there's no actual identification or speciation yet, and we want to continue dosing amikacin. So we then would give the same dose at every 24 hours.
And I guess you and I talked about this before, but you said you don't have to keep checking levels as long as there's no change in kidney function?
Correct. If there's no, just what you said, if there's no change in their renal function, there's really no need to keep checking levels.
Excellent. Well, I hope you guys found this to be useful. Again, our big picture points are that aminoglycosides should be utilized as part of routine empiric antibiotic therapy in critically ill patients who are in septic shock. The way we recommend, the particular agent that we recommend is amikacin for our intensive care unit, and the focus is to use extended interval dosing whenever you can. We discussed the exceptions before. You're going to be checking a level about 10 hours after the beginning of the infusion and using that with the nomogram. Remember, cut the level in half that you get back to determine where you are on the nomogram to determine how often you're going to be dosing the aminoglycoside. Thank you so much for being on the show.
Sure. Thank you for having me.